Good morning, everyone, and welcome to our Precision Health Symposium. My name is Vicki Ellingrod. I'm the Senior Associate Dean in the College of Pharmacy, as well as the Precision Health Education and Training Workgroup Lead. We're very glad that you've joined us here today. For many of us, such as me, this is our first in-person session in a really long time, over 2 years. So we're delighted to reemerge and connect in person. We also warmly welcome those who are joining remotely. There are also many more people participating than those in the room today, so we're happy everyone has tuned in. Precision Health at the University of Michigan launched several years ago, and we have focused on quickly developing infrastructure and tools to help researchers expand and develop innovative investigation. Using our unique breadth and depth of excellence across 19 schools and many disciplines, we are focused on improving 3 key areas: discovery, treatment, and health. At the registration desk today, you can learn about Precision Health membership and its benefits, as well as about our first-in-the-nation Precision Health Certificate program open to our graduate and professional students. You'll also find a copy of our most recent annual report on your table, which describes a lot of the great work being done through Precision Health. For those of you not in the room, you can find all of this information on our website, as well as tools and tutorials and other rich resources designed specifically to support precision health research. We are very fortunate to have strong partners from across campus who share our mission in developing and leading precision health program, including the medical school, the College of Engineering, the School of Public Health, and the Provost's Office. As we work to support all aspects of U of M's mission, research, education, and practice, this day we are setting aside to support our educational mission as we learn from colleagues and experts and develop a stronger precision health community. We have a full agenda today of exciting events that includes a nationally known keynote speaker, 3 distinguished U of M researchers, and a panel discussion. Later, we'll also get an update on precision health resources and opportunities to hear about the new Office of Vice President of Research Bold Challenges initiative. If you need anything while you are here or you have questions, please talk to any of the Precision Health staff. Their badges indicate that they are staffed by having a staff ribbon. And those that are attending remotely, please submit your questions and comments in the chat function, and we will make sure that we address them. We have 1 break planned for today, and that's coming up after our keynote speaker. We ask that you please silence your cell phones while attending the symposium, including you at home, because we don't want you to be distracted. When we get to our question and answer segments, you that are in the room can use note cards to write out any questions for submission, and those that are on the webcast, please use our chat function. We will have staff collecting those, and we will be able to ask our speakers and our panelists those questions. Before we kick off today, though, I want to make sure to thank all of the Precision Health staff who are here helping at this event today. And in particular, I want to thank Tina Krazier, who did the lion's share of the planning for this event. So please join me in a round of applause for all of our Precision Health staff. Now it's my distinct pleasure to introduce a key member of our Precision Health Planning event, Dr. Cornelius James, who is a clinical assistant professor of internal medicine and pediatrics. He leads the Data Augmented Technology Assisted Medical Decision Making, or Data MD curriculum initiative, and he's an educator advisor for the Precision Health Education and Training Workgroup. He is also a mentee of our keynote speaker. So Cornelius, please join me to introduce Dr. Wachter.
Good morning, everyone, and thank you, Vicki. It's been such a pleasure to work with you and Tina on the development of the webinar series, which is culminated in this wonderful symposium, which I believe will be very, very informative. A quick note, I think Vicki mentioned it earlier, that we'll plan to have some time for questions and answers during the event, or questions and answers for our speaker specifically. And if you are physically present in the room, we ask that you use the note cards on the table to write down questions, and we'll have staff that will be available to collect those. If you are attending virtually, then we ask that you use the chat function to submit any questions that you have for our speakers. So today it's my honor to introduce Dr. Robert Wachter, who is a professor and chair of the Department of Medicine at the University of California, San Francisco. He's the author of over 300 articles and 6 books. He coined the term hospitalist in 1996 and is often considered the father of hospital medicine. He is the former president of the Society of Hospital Medicine and past chair of the American Board of Internal Medicine. He's also a master of the American College of Physicians, and he's an elected member of the National Academy of Medicine. In 2015, Modern Healthcare magazine ranked Dr. Wachter as the most influential physician executive in the United States. In 2015, his book, The Digital Doctor, Hope, Hype, and Harm at the Dawn of Medicine's Computer Age was a New York Times Science bestseller. And in 2020 through 2022, his tweets on COVID-19 were viewed more than 400 million times by over 250,000 followers. He has served as a trusted source for information related to the COVID-19 pandemic. Beyond that, I would say that Dr. Wachter is a bit modest related to his piano playing skills, as it's my understanding that he occasionally plays gigs during the course of his busy schedule. He also has many connections here at the University of Michigan through friendships and mentorships. For example, he served as mentor to our very own Sanjay Saint and Scott Flanders. And I've also had the privilege of having Bob as my mentor through the National Academy of Medicine Scholars in Diagnostic Excellence program. He'll also occasionally remind you that he has contributed to the work going on at U of M by paying 4 years of out-of-state tuition for his son, who also met his wife here. So we are honored to have Bob here, and we thank you for making the trip out here to Michigan, and I ask that you now please join me in welcoming Dr. Wachter.
Good morning. What a joy to be here and see real people in person in 3 dimensions. It's just it's a pleasure. And for those of you following at home, nice to see you as well. Look forward to, I know what will be a really stimulating morning. So thank you for that warm introduction, Cornelius. Mentoring and working with Cornelius and learning from him as well has been a great pleasure, and I really look forward to seeing all the things that he accomplishes in his career being in this remarkable place. So that's what I'm going to talk about. I'm going to talk about AI and trying to separate the promise from the hype, because I think there's both. And I hope to frame the rest of the day. I'm really looking forward to hearing the other speakers. There's a lot to think about and a lot going on here and everywhere. So as Cornelius mentioned, I have a little bit of Michigan in my blood. I did pay 4 years of tuition, so you're welcome for what I've done to help support this glorious place. My son had an absolute blast here and met his wife here. And scariest year of my life was when he was president of his fraternity, and I was just waiting for the phone call that something terrible had happened, and luckily it didn't happen on his watch. But he had a great time here. I would periodically wear a Michigan shirt walking through an airport. And of course, you know what happens when you're wearing a Michigan shirt. People say, "Go blue." And I, because I didn't go here, I would hear that and it was like, did they say code blue? And I would start trying to figure out who was down somewhere. But I have to say, I've never met, as people graduate here, you know this, I mean, there's nobody more passionate about their alma mater than people who've spent time here. And he and his wife are definitely among those. So it's a joy to be back here and not paying tuition anymore. So let me take you through what I'm going to talk about. I'm going to talk a little bit about the lessons of the digitization of healthcare so far. And I think those lessons are largely drawn from the electronic health record era, which is, I think, what we've done so far in healthcare is digitize the medical record. And I spent a year of my life researching and then writing a book about that, in part because I found it so surprising and in many ways so disappointing. And I think there are lessons from that experience that are applicable to what the next era will be like, which I think will be, if not dominated, certainly massively influenced by artificial intelligence, machine learning, and associated technology. So spoiler alert, it's hard. It's harder than you think. There are lots of unanticipated consequences. I'm going to talk about what I think you really need to know about AI, assuming that you're not a programmer type or a math major or a CS major, which is me. And so some of the kind of big picture things that I think everybody should understand about it. Some specific areas where AI is likely to make a difference, and then some bumps and of course, it's hard to say, unanticipated consequences to anticipate. Sounds like a tautology, but I think that's actually right. I think we're getting better at anticipating the things that might go wrong. And I think that's going to be very important in AI to the extent possible to begin prophylaxing against that or mitigating against some of the inevitable challenges that we're likely to see. So let's start with the electronic health record as in some ways a model for digital transformation in healthcare. And it's the first thing to point out is how incredibly new this is in healthcare, how this is really a very nascent, young era of healthcare, the transformation of healthcare to largely a digital industry. And this is the curve of electronic health record adoption for non-federal acute care hospitals in the United States. If I showed you the curve for computerization or digitization in physicians' offices, it would look the same. And you see here, there's a take-home message here. This is not a COVID surge. This is, every time we see a curve like this now, oh my God, it's a surge. No, this is electronic health record adoption. You see here, it was tiny up until about 2010. And by about 2013 and 14, it had become dominant in American medical practice. And here's the take-home figure, which I kind of like. Before 2010, fewer than 1 in 10 American hospitals had an electronic health record, and by 2015, fewer than 1 in 10 did not. That is a massive amount of change for a very big battleship, the United States healthcare system, that does not turn very quickly. And so you may ask, like, how did that happen? What created the tipping point? And it turns out it was a federal policy and some federal dollars that got sprinkled onto the healthcare system. $30 billion, which used to seem like a lot of money, not that much now when we talk about trillion-dollar rescue plans. But that's what was devoted by the federal government to subsidize and support and incentivize doctors and hospitals to implement electronic health records. Everybody thinks that was in Obamacare because everybody thinks everything was in Obamacare. It actually wasn't. It was in the rescue plan after the 2008-2009 Great Recession. And if you recall, the rescue plan was we're going to spend $700 billion on what, quote, shovel-ready projects, on projects that are ready to go out the door to try to employ people. And very luckily, and did not have to happen this way, but very luckily, folks like David Blumenthal, Zeke Emanuel had the president's ear and said, you know, we're thinking about shovel-ready projects. I got an idea. Rather than roads and bridges, how about digitizing the American healthcare system? And they dove into that $700 billion money pile and came out with $30 billion devoted to digitizing American healthcare. It was in an act called High Tech. You may know about the Parallel Act, which was called Meaningful Use, which is you had to achieve certain standards if you implemented your electronic health records. There have been a lot of sort of retrospective reviews of meaningful use and some of the things they got wrong, but I actually think it was quite brilliant. I think that for $30 billion, they managed to digitize at the time, $3.5 trillion industry. So that's a pretty well leveraged investment. And even with all the bumps in the road with digitization, people have said, oh, they should have insisted on complete interoperability, that all the computers could talk to each other. That would have slowed it down for 5 years. They had to say, if we get this money out the door today, we will spend it tomorrow on implementing electronic health records. People have said they should have waited till there were systems that were better than Epic and Cerner. Again, none of that would have happened. The imperative was, here's money, let's use it. And I think that we had to have this foundational piece of getting these electronic health records in, and then all the bumpiness, then people moaning about their electronic health record. I think that stage was inevitable, and the sooner we got to it, the better. So we've gotten to it and to some extent through it, although not quite. And so that's where we are today. We basically have digitized at least the core data in the American healthcare system, which is why we're sitting here today. If we hadn't done that, all of the ideas about the spectacular stuff we can do with AI would be meaningless because there would be no data against which AI could do its thing. So the reason AI is now ready for prime time and why there's a huge amount of venture capital investment in new companies using AI is the data are digitized. Now the question is, what do we do with it? And that had to happen, and the electronic health record basically created that foundation. So I'm a digital optimist. I love my iPhone. I make my reservations on, on OpenTable, and I'll use my United Airlines app when I check in tonight and all that kind of stuff. So, my iPhone's pretty slick, and I don't read instructions. I say I accept, and it just seems to work. So that was my view of digital. And in retrospect, a hopelessly naive view. And this was me. It was like, okay, great, we're going to digitize American healthcare. What could possibly go wrong? And also important to recognize that part of what I've done for the last 15 years has been studying patient safety and medical mistakes. And I can't tell you the number of mistakes that felt like they were about the lack of computerization. Somebody prescribes a medicine to which a patient's allergic. Like, duh, can't we fix that? Somebody misreads a doctor's handwriting. Mine is illegible and prescribes the wrong medicine. Duh, it seems like these are all no-brainers. People don't know that the x-ray done in the hospital showed a mass, and that gets missed and the patient shows up with lung cancer several years later. It just felt like this should be easy, and it should be so wonderful that it will solve all of the problems related to data sitting on pieces of paper and getting faxed and sitting on Post-it notes. So that was sort of my attitude about it should be pretty straightforward and should be pretty wonderful. And so let me summarize a 300-page book I wrote a few years ago, as Cornelius mentioned, in 2 or 3 slides, because the entire book basically is about what went wrong, why this is harder than it looks. Here's one thing that went wrong. And again, when you say these things today, people say, oh, of course, but at least I did not anticipate any of what I'm about to tell you for the next few minutes. This is a 7-year-old girl, went to see her doctor several years ago, and she's something of an artist. She drew this crayon drawing of her recollection of the visit to the pediatrician. And it's a really beautiful drawing, and I hope you find it terrifying. So there in the middle of the drawing is the 7-year-old girl sitting on the exam table. Next to her, her mother. In the corner is her sister. And there in the other corner, back to the patient, typing away, is the doctor. And this is the dominant sort of theme of ambulatory medicine these days, where the physician or nurse practitioner, or whoever the clinician is, appears to be paying more attention to and spending more time on feeding the computer than on looking the patient in the eye and attending to their problems. I think it's a spectacular drawing. One thing the kid got wrong, anybody pick it up? So it's the smile on the doctor's face. Because there is not a single physician that I know that is happy about this, that wants to be a data entry clerk, that wants to not be able to focus on the patient while he or she is feeding the computer. But that is the current state. How do you fix this? Turns out the only fix that anybody's really come up with is scribes. And at UCSF, we now employ about 100 scribes. And now we're using digital scribes, whose basically their job is to take on that role of feeding the computer so the doctor can look the patient in the eye again. Scribes were first brought to national attention, I'm a little proud of this, by my wife Katie, who's a journalist and writes for the New York Times. And she wrote an article now 6 or 7 years ago about the emergence of scribes. And that article happened because I came home one day and told her about this phenomenon. And Katie had been covering digitization in other industries for a couple of decades. And I said, honey, do you know what's amazing? Every other industry starts digitizing and immediately they start laying people off. Only in healthcare could we figure out a way of digitizing, and now you have to add an extra person to the room in order to do the job. It's just sort of, it's our unique brilliance as an employment engine. But that was the state of affairs. And people, of course, surveys of physicians starting 7 or 8 years ago, when they asked them about the sources of their unhappiness and burnout, they often listed the electronic health record as number 1 or 2, which of course was flabbergasting because we anticipated that it was going to make the lives of everybody, doctors and patients and nurses, easier and better. So that was one thing that emerged that was surprising. Here's another one that sort of captures the overall extent of the problem. I found this ad for an emergency medicine physician job in Arizona, now about 6, 7 years ago. And it starts out Arizona General Hospital. It's coming to the Grand Canyon State. It's located in a Phoenix suburb. It's a little tiny boutique general hospital, which sounds kind of nice. And then the ad begins. And here's what they're selling. They have an ER, which is, if you're looking for an ER doctor, you do want to have an ER, so that's nice. They have a radiology suite with some of the latest gizmos. 2 state-of-the-art operating rooms, a little tiny place. Outpatient surgery, 16 inpatient rooms. But there was only one part of the ad they put in bold. Clearly, they thought this was their main selling point. In the ad, it said, "We have no electronic medical record. You can come here and scribble on pieces of paper." And they thought that would be an attractor. So that was sort of emblematic of how bumpy the implementation of electronic health records was. And there are a whole lot of other things that were surprising and went wrong that I don't have time to go into now, but we can talk about later if you'd like. So let me tell you about the lessons that at least I learned from watching the first 10 years of digitization in healthcare. And I think these are relevant to what the next 10 years will be, and AI and precision medicine and all of the associated sensibilities and technologies will be key there. Here are some of the lessons. First is, and I got this really not from looking at healthcare, but looking at the digitization of other industries. And one of the nice parts about studying healthcare digitization is you can look at pretty much every other industry and see what digitization looks like, because we are so late to this dance. I'd say the only industry that's probably behind us is education. And so when you work in academic medicine, you have the joy of being in the 2 laggard industries fused into one. So we're particularly challenged. But here's the lesson. The lesson is that digitization has to go through 4 what are semi-discrete stages. There's a little bit of overlap and you have early adopters, but I think this turns out to be a fairly useful way of, at least I found, of thinking about this. The first is you have to digitize whatever the thing is, however you store and move around data. The second thing is you have to do what we now know as interoperability, sort of connecting the parts so the data flows relatively seamlessly across the system. And you know, the sort of usual example of interoperability is that I can take my Bank of America card and put it in a Citibank machine, and it knows who I am, and it spits out $200 and charges me $3 for what must be a transaction that costs them about 1 cent. But nevertheless, it's pretty cool that anywhere in the world I can put in that card and it knows me, and it cuts across digital systems. So in healthcare, what are connecting the parts? In about 5 years ago when I was thinking about this, it mostly was connecting these big enterprise systems, you know, my Epic system with your Epic system, my Epic system or your Epic system with the Cerner system of a hospital you've just bought or partnered with somewhere on one part. Everybody's got a hand here about the state. I don't really get it, but some different part of the hand. But the big issue in interoperability today is less about that and more about a third-party tool, some new cool digital thing, some new AI algorithm, some new app to take care of people with diabetes. Does it plug into your Epic system in a seamless way? So there's sort of different kinds of interoperability, but the idea is a digital ecosystem where everything flows frictionlessly, and think your GPS system, you know, how that works, or the banking system. So that's the second thing. Now it gets harder. Those are the easy things, believe it or not. It gets harder here, which is, and this is a large part of what you're all thinking about, gleaning meaningful insights from all of that data, taking all that data, sloshing around through your digital tubes, and getting smarter about your business. Your business can be how to take care of an individual patient. Your business could be how to organize this massive healthcare system and deploy people and make it easier for a patient to make an appointment or pay a bill or you name it. But that's the idea, is we're taking our data and using it to be smarter about what we're trying to accomplish. And now the fourth, the holy grail and the hardest thing of all, is converting those insights into actions that improve healthcare value, value being shorthand for quality, safety, patient experience, access, equity, divided by the cost. So you're making it better and cheaper by virtue of the insights you got from digital data. Some of the time that number 4 is done through other digital tools, and some of the time not at all. It's done, you're smarter about the thing, and you're deploying your nurses in different ways, or your doctors in different ways, or pharmacists in different ways, or patients are able to do things for themselves they couldn't do previously, predicting things better. There are 100 things you can do around number 4. Here is my scorecard. I think we have done, in 2022, I think we've done number one, pretty much. I told you we're essentially 100% digitized in terms of the medical record. If you look in the system, if you go to a nursing home, not so much, and mental health, not so much. There are gaps there, but by and large, the system largely collects and stores and moves data around in basic ways in digital form these days. We're sort of plus minus on this. My Epic system and your Epic system talk pretty well to each other. My Epic system and the Cerner system don't. The plug and playness of a new app, pretty tough. Epic likes to tell you, oh, we're making it easy, but they're actually making it as hard as possible because they actually don't want you to do that. They want you to use their thing, which they will tell you they're working on and will be out next year and will be wonderful. All of that stuff is still at play. So I give it a plus minus. I think we've done virtually none of this, and we've done virtually none of this. So we've really, when you think about what's the point of all this digitization, it's really number 3 and 4. It's to get insights and then to figure out how to change our work to make things better for patients. And I'd say when I look around, it's really underwhelming what we've done in the 2 key parts of this staging. Will it happen? Of course it will. But the question really is how long it will take and how bumpy the road will be. Now, I happen to be lucky enough to have my son who went here works in an industry that does all 4 of these things extraordinarily well. And his job is actually number 3 and number 4. And so he'll periodically, we'll get into a little argument periodically about whose work is more important. And he'll make the argument that obviously mine is, because my industry has made this investment to do all of this stuff, and that yours obviously hasn't. So his industry is called Major League Baseball. And this is him, he works for the Atlanta Braves, so he is now a World Series champion. That's his wife, who also graduated from here, and that's him on the field as they won last year. And I talked to him about what he can do, and it's breathtaking. He can tell you that this guy cannot hit a low and outside curveball on Tuesday nights when the wind is out of the southwest and the pitcher is over 6'2". And he asked me, what can you do, Dad? I said, well, we have these sepsis alerts. And that's sort of it. And they're only wrong about 30% of the time. And like, that's our big triumph in terms of using our data to get smarter about our work. Just shows how far we have to go. And part of why is his job. That the Atlanta Braves believes that it is worth having about 10 or 15 or 20 Dougs around to take this perfect data they have. Every pitch is analyzed, to the 100th degree. How fast it's spinning and the launch angle. They have perfect data, and they believe that it's worth having all these people whose job is to analyze it and process it and come up with intelligence about it and use it to tell the pitchers about how to pitch against the next team coming in or how much it's worth spending on a given player because this is the value they bring to the team. And you look at that and look at, do we do any of that in healthcare? And the answer is almost none of it. And we're not governed that way. We don't have the people to do this work. And even our world, for those of you, one of the real challenges I've been talking about for the last couple of days is we have people working on this from a research standpoint. But for the most part, in many systems, there's a real struggle with how you then connect them to the clinical enterprise and trying to figure out that tension. In academic medicine, it's sort of organized that way. You have the clinical thing, and then you have the research thing, and there's some cross-subsidization, and they kind of talk to each other a little bit, but not so much. Well, that was fine if the research is you're in the lab looking at mitochondria in the left lobe of the liver, but it's not at all fine if what your research is taking clinical data and trying to get smart about it and use novel methods to understand it better and then deliver it into the healthcare system and make care better. That's pretty tough, and so just figuring out that structure and governance is pretty tricky. Okay, one other lesson before we sort of get onto AI that I learned from studying health IT for its first 10 years is what I call the mother of all adaptive problems. So this is a way of thinking about change in complex organizations by Ron Heifetz, who's at the Kennedy School at Harvard. And he talks about adaptive problems versus technical or technological problems. Adaptive problems are those that require people themselves to change. And adaptive problems, the people are the problem and the people are the solution. And leadership is about mobilizing and engaging them with the problem rather than trying to anesthetize them so you can go off and solve it on their own. It's very easy to think about health IT as a technical problem. it's technical after all. It's like you build it, you put it in, and you're done. And I think one of the dominant lessons of the first 10 years is that just does not work. And it did not work with electronic health records, and it will not work with artificial intelligence. If you've solved the technical problems, you have some slick way of developing algorithms and thinking about it, you've done 10% of the work. You now have to think about how that gets deployed. You have to think about the people and the workflow and the politics. I was talking with Cornelius this morning about, will AI eventually replace radiologists? I don't know, maybe, maybe not. But I do know that the technical piece of getting AI to read a film as well as or better than radiologists is about 10% or 20% of the challenge. It's then, how do you make that work? How much pushback are you going to get from the legacy field? How does that all work? What's the business model for the companies? Is Google going to get sued by a patient if something is missed on the X-ray? What's the ethical framework to thinking about all this? That's the hard work. In some ways, the technical stuff is the easiest, and that's one of the lessons of digitization in healthcare so far. Okay, so you came here to hear about AI. I've said almost nothing about AI so far. You're wondering what the hell I'm doing. So let's toggle to AI, and let's and you'll hear some of the same themes, but I think the foundation, hopefully, that I just gave you is helpful. So let me start with AI without the nasty math. I need to make a point that I was a political science major in college, not math, not CS. I really don't understand any of the technical piece of AI. I don't code. I don't know all these languages. And I have to say, when I became chair of my department at UCSF, I've got a huge number of basic scientists that work in the department. And they thought, like, what's going on here that this guy is now chair? And I met with them in a room like this. And I said, you folks should know that I was a science major in college. And then I said political science, which I thought was hilarious. And they were like absolutely stone-faced, like, oh my God, this is worse than I thought. So anyway, when it comes to AI, and those of you that do the technical components of AI sort of understand where I'm coming from is not where you're coming from. And I have no idea what that is. I don't know what that is. I don't really know what that is. The way I think about AI is sort of like this. There's like some math, a miracle happens, and then there's some other math and an output that turns out to work. So I'm going to leave it to all of you to figure out what that miracle is, and I do think it is actually quite miraculous. And how do I know that? I know that because in the rest of our lives, AI, of course, is embedded in everything we do. When you do a Google search, or you go onto Netflix, or you're figuring out your way to drive somewhere. I live in San Francisco, and about half the cars on the road are driverless and running around. I mean, if you took a step back and thought about it, it is miraculous. It's remarkable what is going on. And it all has AI sort of embedded in all of these tools. And in some ways, when you think about healthcare, it's remarkable how much we are the exception. When you think about how important it is, how much money we spend on it, the fact that there is so little digital intelligence being applied, whereas there's a tremendous amount that's applied every time you go onto Netflix, and it's suggesting, you should look at this movie because you like that one, or it's showing you a different picture. There are, it turns out, about 10 or 15 different ways of showing the picture depicting a movie, and it knows which one is going to make you more likely to click on it. That's stuff we've invested trillions of dollars in, whereas improving the lives of patients is something we've invested almost nothing in. So it's pretty amazing. But anyway, there's a lot of AI in our lives, and we recognize that. If you think about the history of AI in medicine, it's not new. There were efforts to take artificial intelligence type of thinking and embed it in medicine. They really began in the 70s or 80s with some pioneers, some of whom were here. There were folks at Pitt and at Harvard and a few other places. And they chose, as Cornelius mentioned, he's part of a National Academy of Medicine program on diagnosis. They chose to focus on diagnosis. Why? I've spoken to actually some of the founders. It seemed to them to be the most interesting problem. In retrospect, probably a mistake, because it turns out to be the hardest problem. If you figure out how tricky it is for a physician to take in all this data, and the challenge, of course, is not just a list. Chest pain, check. is one thing in an algorithm, but chest pain is the patient saying, oh, and by the way, doctor, my chest hurts a little as their 12th problem versus I have chest pain. Those are two very different things and very different to program that into a computer and know that those are two very different things. Doctor, of course, knows immediately that those are two different things. So pretty tricky to do. And here is a cartoon that depicted how tricky this was to do. Patient seeing a doctor, rapid pulse, sweating, shallow breathing. According to the computer, you've got gallstones, even though the patient has an arrow coming out of his back. So this was sort of a little bit of a mockery of how much bad output these early programs delivered. And it led to what sometimes is known as the AI winter. That basically AI was felt to be a failure, not ready for prime time because it really did not, the problem of sort of replacing the physician's brain as a diagnostic engine turned out to not be a tractable problem. And so rather than saying, let's go back to the drawing board and work on easier problems, like how do we schedule staff to come into the ER on which day, it kind of went into hibernation for almost 30 years. And then starting in the early 2000s, it was interesting because the big tech companies decided it was time. They had figured out AI and parallel technologies in their other industries. They began to say, it's time for us to go back into healthcare. This is a huge industry, a lot of money, clearly doesn't work as well as it should. It's now our time. I was on Google's advisory board in 2005 when Google decided that. They built something called Google Health in 2005. Microsoft built a parallel thing called Microsoft Health Vault. And our advisory board lasted about a year and a half. And then I remember Eric Schmidt, who was the CEO at the time, coming in and talking to our advisory board about 2006-07. And he said, we're disbanding this. This is too hard for us. And I said, whoa, too hard for Google? That's impressive. And what I think he meant was that the technology was very good, but because the electronic record had not been implemented yet, they were trying to deliver AI and associated tools without having the data begin life in digital form. So if in order to use Google's health record, you had to take all of your records and re-enter it into this special Google portal, that was just not going to work. And that's what they found. And they basically disbanded for about 15 years. They've tried it again recently. They've disbanded sort of again recognizing how hard it is, even though they came into it with their eyes much more wide open this time. So it's hard stuff, and the early experience, I think, was mostly disappointing. Here, though, I think we're entering a new era. I think it's an exciting era, in large part because the data are in digital form, and in large part because people recognize the opportunity. There's a huge amount of investment going into the field. And this is from an article Eric Topol put together a few years ago, looking at just the wide variety of problems in healthcare that are potentially amenable for AI type solutions. And I won't go through this. It's basically everything from reading x-rays and EKGs to improving patient safety to predictions to using Alexa-like voice assistants. You may have seen recently that Alexa just partnered with Teladoc. So when you say to your Alexa, I have a cough today, Alexa can say, do you want to talk to a doctor? And then a Teladoc doctor will come on. So you see the morphing together of different ways of approaching these kinds of problems. So it's a pretty exciting era that we're beginning to enter, in part because the technology's gotten better, in part because we begin with an electronic record where the data, the foundational data, is all digital. And here is from a company called CB Insights that keeps track of this, just a partial list of the healthcare AI-oriented startups, and you see they're in every field. A huge amount of venture capital going into this. Clearly, the VC world has decided that AI in healthcare is now reaching prime time, and that there are going to be opportunities in all of these fields for companies to come in and figure out ways of using the data and creating tools and outputs that become marketable and can be profitable, or else they wouldn't be in this. And it's everything from drug discovery to imaging and diagnostics to virtual assistants, clinical trials, remote monitoring. It's pretty much in every field in healthcare. You can assume most of these companies will be out of business in 3 or 4 years, but there will be a few that will do extraordinarily well. So here are some of the questions that I think will be eventually answered or tasks addressed by AI and big data. I think diagnosis will make a comeback. It is a very, very hard problem, but there are some of the top AI companies in the world working on it. And so teaching computers to identify cases of lung cancer from path slides, or even creating a differential diagnosis based on what's in the medical record, I think is coming. A lot of effort done on risk prediction for developing disease or outcome, predicting sepsis or sepsis mortality, predicting chances of deterioration, all things I've already heard in the last couple of days that you're working on. Several of you are already working on here. Predict treatment response, so sort of precision medicine is a pretty wastebasket term. It can mean 100 different things, but one thing it means is predicting the response to treatment of a disease like hypertension or cancer based on genetic data, which I think seems to me to be quite a tractable problem, but creates a new set of problems that I think are going to be worth thinking about. And this gets at the challenges here of it's not just coming up with a technical solution, the implementation of the solution is very tricky. So saying to Cornelius this morning, you know, if I'm doing ambulatory care, in my sort of decaying neurons, I can sort of remember that you treat people with high blood pressure with this medicine, but if they're over 60, you treat them with that medicine, and maybe if they're female, you treat them with that medicine that seems to work better in different groups. Can I possibly remember that if you have a patient with high blood pressure who has this gene pattern, that they do better with this medicine? Absolutely no way. So the only way to implement true precision medicine is going to be embedding decision support into the electronic health record, which, as we've already talked about, is incredibly challenging to figure out how to get that right. But the science here, I think, is going to be tractable. And improving practice, this may turn out to be the first place where you see AI really flourish in healthcare. Things that are really less about taking care of individual patients and more about organizing the logistics of this incredibly complex system. So predicting clinic demand or no-shows or helping the physician complete a note based on prior examples are all things that companies are working on and I think are tractable. So let me sort of give you a couple of examples of ways that I think this is going to play out. Certainly the work in deep learning in radiology is very exciting. It turns out that the computers are pretty good at looking at and reading x-rays. One of my favorite movies is The Fugitive, and if you recall that movie, when Harrison Ford goes into his old hospital and makes believe he's an orderly even though he's a physician who was charged wrongly with murder, and he's wheeling a patient to the operating room because I think he's an orderly, and he pulls up the x-ray and realizes there's a big pneumothorax and they've misdiagnosed it, and he saves the patient's life. He tells the doctor, and the doctor goes and treats the patient. Sort of pretty cool, but what it said basically is we need some person to look at this x-ray, this bunch of pixels, and realize the patient has a collapsed lung, a life-threatening condition. This is a new GE X-ray product that we folks at UCSF did the technology behind, and it automatically reads whether the patient has a pneumothorax. And so that's kind of useful because all these X-rays done in the middle of the night are normally just put in a stack for the radiologist to read first thing in the morning. But if it says you have this potential life-threatening condition, it gets prioritized and can be read immediately. So more and more of that, I think, is coming around the corner. This is now embedded in a GE product. Pathology slides, again, anything that's visual representation that really is a bunch of pixels and a human is trying to sort it out, that can be done by through AI. Here's a company that does this, just got $165 million in funding. This is a product that we're using at UCSF. As I said, we've hired a lot of scribes, mostly pre-med students, to come into the room with the doctor and feed the computer so the doctor can look the patient in the eye. It's expensive. The kids end up leaving to go to med school, so you have to keep retraining them. And so we're now working with a San Francisco-based company that basically uses an Alexa-like device to do the same thing, to take in the data and, at least at first pass, using AI to create a first version of the note. You may say, that's not what's so hard about that? That's like dictation software. Turns out it's not. It's much harder the problem than that, because just the dictation of a 15-minute note of the doctor and patient talking to each other is almost worthless. You have to take that and then turn it into what a note looks like into the right categories, to edit it quite a bit. So there's a lot to do here, but the technology is now getting ready pretty much at prime time. And here's one that a lot of companies are working on, not quite figured out, gets to something that becomes a little harder than just reading an x-ray or a path slide or taking the language of a clinical encounter and turning it into a note. This is sort of what's known in aviation as flight path monitoring. It's if the last 10,000 flights followed this path and you're now in some different path, something must be wrong. Understanding that and then providing input to whoever is flying the plane that, you know, what's going on here, you're not on the correct path. So what would that look like in healthcare? So a patient who's not, their fever is not going down within the time frame that the last 10,000 people with pneumonia's fevers went down. And so the computer, you could see saying to you, patients like this are usually afebrile for now. Maybe you should rethink your diagnosis or rethink your therapy. And if the computer starts getting a little snarkier, you could see something like this. It's very unusual to see a patient with GI bleeding still on an anticoagulant. You're either very innovative or very wrong. You could see something like that playing out eventually. So let's assume AI gets it gets really good technically. Diagnosis, prediction, understanding an outlier, improving, developing and writing an electronic health record note, then what? So here's just a bit of evidence of how good it is getting and will get technically. Here's the CEO of Google at a presentation a couple of years ago where he talked about the computer's ability to diagnose diabetic retinopathy, a condition that you see in the blood vessels in the back of the eye, as well as, if not better than, a trained ophthalmologist, and much better than a primary care doctor like a generalist like someone like me. And not only is it better at doing this thing that doctors have trained to do, diagnosing this condition in the back of the eye, but it turns out that the computer can tell things that doctors can't tell themselves. So for example, the computer can tell you what gender the patient is by looking at the blood vessels in the back of the eye. When you ask an ophthalmologist, they tell you, I can't do that, I have no idea. And nobody can figure out actually what the computer is doing either. It just does it with total accuracy when you feed into it 10 billion images. So it can predict all sorts of things: biological sex, age, blood pressure, smoking status. It can predict all of those things if you feed it enough data. So let me just turn the last few minutes to talking about, let's assume the technical piece gets worked out. Those of you that do the technical piece, please work it out as quickly as possible. I think it will get worked out faster in things that are about looking at a bunch of pixels. It's path slides, that's x-rays, that's skin lesions, stuff like that. That's looking at the back of the eye. Harder in things that require sort of higher level cognitive work. That's making a diagnosis or a treatment. So let's talk about them. I'm not going to spend any time, in part because some of your other speakers today are going to spend some time on some of these, but I think there's a whole bunch of traditional concerns. I think you probably have heard them, so I'm just going to list them for you before I turn to some other things that I don't think are talked about quite as much. First, garbage in, garbage out. If what's in the medical record is fiction, which periodically it is, because of course we're paid better if we write certain things than if we write other things. It's part of what the computers do, is it prompts us to write it a certain way so that we get paid better. Then what the output is also going to be garbage out. So a lot of electronic health record that's fed into AI generators is from billing data of dubious accuracy. And data from one organization or setting may not be relevant to another. That may be different demographics, it may be a different culture or context. So there's that problem. If the data that's in is not really good data and accurate data, then your output is obviously going to be influenced by that. This black box phenomenon I think is very real, that will clinicians follow predictions and recommendations whose derivations they don't understand or that have no obvious biological plausibility. New AI programs are trying to address that by basically saying, I think the patient has disease X, and then giving you Y, or putting probabilities down on their outputs. I don't know how big a deal this is. People talk about this a lot. I actually have no idea how the clinical laboratory works, but when they tell me what the creatinine is, I say, good, I believe you. So I'm not sure that we absolutely have to understand it if the accuracy is unassailable. Will there be a mechanism to follow up on accuracy and effectiveness and to iterate? I think that's a big issue, and I'll get back to that in a second. A lot of ethical issues. We're going to talk a little bit more about that later. So, and biases and disparities, more and more stuff coming out about these issues. It might appear that if you just look at the AI and the data, it turns out that Black patients are getting less pain medicine for the same fracture than a white patient. You could throw that into an AI engine and it says that, okay, the right way to treat a Black patient with a fracture is with less pain medicine than a white patient, as opposed to what it really is, which is a reflection of a bias. And so can the system disentangle those things? Melanoma detection is less accurate in people with dark skin. So the context may influence the accuracy of this, of the result, and the biases that are embedded in the system. The last thing you want to do is then hardwire those biases into your outputs. And of course, then the issue of the digital divide, and if so much of medicine is now being provided through digital tools, what happens if you don't have good wireless or you don't have an iPhone or whatever? So those are things that I think people kind of get and are understood. And then obviously all the privacy and security issues, and somebody can, if an algorithm is determining something really important for a patient and somebody hacks into it, that obviously causes a whole set of real problems. So let me spend a couple minutes on things that I think are maybe a little bit less obvious, but ones that worry me. How is this actually going to work? I think the lesson of the electronic health record era is how you think it's going to work, and how it worked in the PowerPoint slides that you looked at when the consultant sold you the machine is very different than how it's actually going to work in real practice with real people, with real economics, cultures, systems, all of that stuff. So I'm going to say just a word about each of these. Integration and interoperability. A new middle layer that connects patients to the system, the AI version of alert fatigue, and then something called data set shift. How good is good enough? And this is the version of this we're getting more comfortable with, is the driverless car problem. How perfect does this technology that we're handing over agency to, how perfect does it need to be before we accept it as being useful? The de-skilling of the people, and the politics of AI. I'm going to spend a minute on each of these. So here's interoperability. I kind of like this analogy. This is the laying of the golden spike in Utah. And if you recall, the American railroad system was built on 2 different gauges originally, so that trains actually from go to one place to another had to be picked up and moved onto a different set of tracks, or a different train needed to pick it up because they were not the same gauge. So we really need, although some of the AI solutions will come from Epic, or Cerner, or whichever EHR company, most of them will not. Most of them are going to be built by third party, some of those companies I showed you, and then it's got to be able to be embedded in your enterprise system seamlessly. If a patient or a doctor or nurse has to leave Epic and go into a different thing to get the AI recommendations, it's just simply not going to work. No one has the time. So we really need a plug and play iPhone App Store environment. And nobody really has laid the golden spike now. And as there's more and more data coming from your phone or your watch or your Alexa or your genomics, the fact that it absolutely does not seamlessly connect with your enterprise Epic or Cerner system is a very big deal, has to be solved. Whether it gets solved by federal regulation or solved by technologies that weave these things together, hard to know, but it absolutely has to be solved. Here's the one that's not specifically AI related, but I think there's an AI component to it. As more and more patients are having data monitored in their real life from their phone or their digital scale or their digital glucometer, just heard about a company who just got $30 million investment for their digital toilet seat. You sit on the toilet and it measures your vital signs. It's not going to be very long then for the digitization of what's in your toilet and your serum and your electrolytes to be measured by some measure of your urine. This is not sort of fantasy anymore, sort of new meaning to the idea of streaming data. How does that work? And periodically I'll hear digital optimists say, oh, this is going to be great. Because what's going to happen is all of that data is going to stream to the primary care doctor, who's now going to be so happy to have all of this additional information on each of his or her 1,600 patients. I have about 300 primary care doctors work for me. If I told them that this is happening today, they would all quit by 5 o'clock this afternoon. That is not doable to have that kind of flow of digital data coming in from patients in their day-to-day life continuously. Not going to work. And so what has to happen is there's got to be a new layer built into the system, and there's going to have to be a lot of AI in that layer. And we've sometimes called these people care traffic controllers. They're between the patients and all the data and the frontline clinicians, sort of taking in these data streams, prioritizing it, triaging it, figuring out what to do. And here are some of the things that you could see the care traffic controllers doing. Patient 112 sugar is high again. The algorithm bumped the insulin, but let's get the coach involved. So what you see here is the data coming in, it's recognizing there's an outlier. The algorithm, we've now given it agency to actually change a prescription. Pretty big deal, better be sure we get that right. It's not working. The algorithm has figured out that the response is not good enough, and now there's a prioritization escalation strategy that gets someone involved, but here the strategy is let's get a coach involved or get a pharmacist involved, and not necessarily a primary care physician, not necessarily an endocrinologist. So think about all of the stuff that has to happen there, the weaving together of the different layers of escalation, the algorithms to see that the patient, this particular patient's sugar is not right, to then make a recommendation about what is the right thing to do that understands the patient's context and allergies and prior history. You know, this is not trivial stuff. This is like a decade to sort all this out. If you want to trivialize it, what you say is all the data will flow to the primary care doc and they'll figure it out, which is like just not going to happen. Patient 42 has an irregular heart rate and is short of breath. Let's do a televisit as soon as possible. Maybe happening. Patient, this is now the Internet of Things, gets a little bit even more fun. Patient 13's weight is up and oxygen saturation is worse. I'll lock the salt shaker and the refrigerator. So in the Internet of Things, everything's wired in the house. So now the intervention is not just a medicine, but maybe something that influences the patient's behavior. None of this is happening today, but this layer is going to have to be built as more care is drawn from data that is being collected in real time on patients sitting in their home or in their workplace. Just spend a minute on alert fatigue. There's not an analog yet in AI, but there will be without question. It's one of the lessons of the first years of the electronic health record era, which is, all right, we have all this data. One of the things we can do, which is sort of almost the simplest thing, is to say, here are the boundaries of the data, and when a patient's data point is outside those boundaries, what's our response to that? We're going to alert the doctor or alert the nurse. Sounds great, except this is a study that Barbara Drew at our place did now 8 years ago. She looked at the 70 ICU beds we have at UCSF Medical Center, and she asked the question, each one has one of those monitors. It's monitoring about 5 pieces of data, heart rate, respiratory rate, oxygen saturation, EKG tracing, a couple others. And so Barbara asked the question, in a month, in those 70 beds, how many alerts are discharged, alerts, an audible alert or a visual alert saying something is wrong, doctor or nurse, we need you to react. Anybody want to take a guess? A month, 70 beds? What do you think? 500,000. Really? Boy, that's a lot. 500,000, Jesus. You're wrong by you're underestimated by 5-fold. 2.5 million alerts were discharged by these machines in a month. There was an audible alert every 7 minutes. And Barbara told me that she was interviewing a nurse once by the bedside, and the alert kept popping off, and Barbara kept jumping, and the patient's family was jumping, and the nurse was completely calm. And Barbara turned to the nurse and said, like, what's going on? Like, what would make you worried about something going wrong with the patient? And the nurse thought for a second, and then the nurse said, silence. She said, if there was no alert, I'd be really worried, which of course is like, on Seinfeld, they call that bizarro world. That's like completely backwards, that the absence of the alert is what gets you worried. So clearly the alerts don't work. And that is a huge problem with data coming in and immature systems, triaging them, prioritizing them. And that's the system that we have. And AI could make that even worse if we don't get our acts, get this together. So if the effector arm of AI is alert the clinician, we're likely to replicate the problems with alert fatigue. And here's the sepsis alert on Epic, which is wrong a lot. And so clinicians learn to sometimes ignore it. Sometimes the computer doesn't let them ignore it. And sometimes because it's a false positive, it causes them to do something that actually is not the correct thing to do, like the worst thing to do if the patient actually doesn't have sepsis but has heart failure, is to give the patient a ton of fluid. But that's the right response if you have sepsis. So unless the test characteristics of the alert are so good that that error rarely happens, you can actually harm people. So all of this is going to play out in AI in a different way that it's played out for data in general. Here's a new one. Some of you who work in this field know this, but I wasn't aware of it until I just read this last week. In Stat News, AI Gone Astray, How Subtle Shifts in Patient Data Send Popular Algorithms Reeling, Undermining Patient Safety. This is a phenomenon. It's called data set shift. And what they showed is in their sepsis model, it just had its way of reading all the data and using diagnostic codes as one of the inputs, and then putting out an alert saying the patient has sepsis. The problem was in 2015, the clinicians began using a different set of diagnostic codes because policies changed. And so beginning at that point, the algorithm no longer worked. But there was no way that the frontline clinicians could know that. They're blithely using the algorithm because it's there and it sort of has some authority associated with it. The computer says it's right. I believe the computer. And yet by the end of this, using the original algorithm, the test characteristics were really no better than chance. And so no way that clinicians knew this. There was no iterative learning system where you could sort of recognize that the algorithm, which had been fine in the beginning, was now failing. So really, I thought, interesting problem and something we've got to pay attention to. So from this article, the findings strongly suggest a vexing culprit known as data set shift. It occurs when data evolve with the world around them, but the algorithm remains locked in the time period in which it was trained, like an explorer navigating with an outdated map. Eventually, it becomes hopelessly lost. I didn't know that that's a thing, but now I know that's yet another thing that makes this very, very difficult and creates a need to iterate and sort of check on your accuracy over time, which is sort of one more level of complexity. So shifting to a last couple of things, the driverless car problem. So AKA, will and should we trust AI in life or death situations? So it's part of the political complexity here. You can say that the algorithm is as good at reading a path slide as a doctor, maybe even better, and plus it can work 24/7 and it doesn't have burnout and it doesn't have a bad day and all that kind of stuff. You can say that, but what happens when then you take the doctor out of the mix and say, this is what we're going to trust? Well, we're learning about that with driverless cars, because driverless cars are really good and really accurate and get it right virtually all the time, but periodically don't. And this was one of the famous early accidents. This was a Tesla that didn't stop, that didn't catch the truck coming around the corner and plowed into it, killing at least one person. I forget whether more died. And here's a headline in Wired magazine: Feds say Tesla autopilot partly to blame for 2018 crash. Of course, this sets back the driverless car industry by several years. Is anybody going to provide insurance? Do you sue Tesla? Do you sue the driver? The idea that the driver's got to be paying attention when the car is driving itself, of course, is impossible. How do you do that? And so this kind of thing, a single iconic accident that makes the front page of the newspaper, sets the idea of giving this technology agency over the humans back tremendously, sort of independent of the fact that nearly 20,000 people die in crashes involving distracted drivers every year. So it probably is true today that if we all changed to driverless cars, there would be fewer traffic deaths on the highway. That's almost undoubtedly true, because you have drivers falling asleep at the wheel and drivers checking their text messages while they're driving, not problems with driverless cars. But it's an apples to oranges comparison. It's very hard for a society to say, on aggregate, it's safer, because every time this happens, it will become a front page story of the technology failing. Look, we told you, you need the person. So as you think about the ease with which computers will replace your radiologist, think about the driverless car problem, because the first time the computer misses a cancer, it will be the front page of the newspaper, forgetting about the many, many, many other cases where the doctor missed the cancer. That's just a natural phenomenon. Deskilling in the face of automation. We've seen this play out in aviation. You may not know this, in the old days, circa 1970s. There were actually 3 people in the cockpit of a large plane. There was a pilot, a co-pilot, and a flight engineer, someone looking at the maps and all that, believe it or not. And then they said, we don't need the flight engineer anymore. And now there are 2. And there's a saying in aviation that eventually there won't be 2 people in a cockpit. There will be a pilot and a dog. And the pilot is there to keep the dog company. The dog is there to bite the pilot if the pilot tries to touch the controls. That's sort of the end game of where this is going as the technology gets better. And that's, sort of amusing and probably to some extent true. In many ways, it's a driverless car issue that you now have a driverless plane as the technology gets better. The problem is we're not there yet. And yet the planes have become so technologically sophisticated that what is happening is the pilots basically are not learning how to fly the planes if the technology fails them. And this is, you might say, oh, it's terrible, you got to do something about that. It's a completely natural phenomenon. As the computers take over, we give them agency. We do it appropriately because our brains are busy. We got other stuff to do. I will confess to you that I really do not remember my wife's cell phone number, and that if I ever lost my phone, I might never see her again. And why do I not remember it? Because in my phone, I can always look it up. It's a piece of data I really don't need to remember anymore. So it's quite natural for us to lessen our cognitive load by giving the agency to our technology when we trust it. The problem is if we over-trust it and then the technology fails us, the question is, do people still have the skills to do the thing they used to do? And what we're learning in aviation is not really. And this is a really remarkable piece in the New York Times Magazine a few years ago, looking at the crashes of the 2 737 MAXs, where clearly the technology failed. They rejiggered the technology, so they changed the plane and changed the engines. And what happened was sort of out of the blue, all of a sudden the computer started forcing the plane down, basically down into the ocean, tragically. But as folks have analyzed this and analyzed all the flight tapes and the black box data, it became clear that a skilled pilot could have figured out what was going on and solved the problem. And yet the 2 pilots that were at the helms of these planes did not, and there were a few other aviation accidents in the last 10 years that have a very similar feel. And here's from this article in the New York Times Magazine about the Lion Air cockpit co-pilot. His experience with flying was scripted, bounded by checklists and cockpit mandates, and dependent on autopilots. He had some rote knowledge of procedures as handed down from the big manufacturers, but he was weak in an essential quality known as airmanship. Sadly, his captain turned out to be weak in it too. Airmanship is an anachronistic word, but it's applied without prejudice to men, women as well as men. Its full meaning is difficult to convey. It includes a visceral sense of navigation, an operational understanding of weather and weather information, the ability to form mental maps of traffic flows, fluency in the nuance of radio communications, and especially a deep appreciation for the interplay between energy, inertia, and wings. Airplanes are living things. The best pilots do not sit in cockpits so much as strap them on. I think that's really brilliant. And you can see the exact same thing happening to doctors and nurses and pharmacists as the computers get better and take over more of our lives. And then when a bad thing happens, we'll say, oh, they were asleep at the switch, in the same way that we'll say that Tesla driver should have been paying attention because this might happen. If it's a 1 in a million thing, they're not going to be paying attention. It's just not a human characteristic. So I think an interesting problem, and those of you who think about training are going to have to think about how do we deal with this issue of de-skilling until the technology, of course, is perfect, because then we can just get rid of all the humans. But that's going to be a while. So maybe last comment on the political economics of healthcare AI, and this may turn out to be the hardest thing of all and the biggest obstacle. So the pressure for value, meaning a healthcare organization is only going to survive if it figures out ways of delivering high quality, safe, satisfying, accessible, equitable care and does it at the lowest possible cost, will lead competition to push care toward tech-enabled solutions. So moving from specialists who are more expensive to generalists, if the generalists can be helped in their work by using digital system. Moving from generalist physicians to non-physician clinicians, moving from those to coaches, moving from those to patients and families. This is sort of the world of technology, trying to deliver solutions so that less expensive people can do stuff that it used to require more expensive people to do. You've seen what that looks like in the rest of your life, in the way you handle your finances, and the way you handle travel and other things. So will patients be willing to pay? I hear this all the time. But the patients are going to want the human touch of a doctor. Maybe, I don't know. I mean, I used to think I liked going to talk to my bank teller, but I never want to see my bank teller again. I'm perfectly happy with my ATM. So patients' willingness to pay for higher priced, more personal entities, I think will be determined empirically. Some people will, in the same way many people use TurboTax, but some people pay for an accountant. Many people use online travel tools, but some will pay for a travel agent if you can find one. So, and they'll pay for it. So patients' willingness to pay for this will determine whether those people even exist. What does that look like? Concierge medicine is sort of demonstrating what that looks like in medicine, travel agents, tax preparation. And this includes the value that people place on human touch and empathy. Do they value it? Do they really want to see a doctor? Maybe. We'll see. We'll see if they're willing to pay for it. There may be some tasks that incumbents are happy to give up to technology if they're menial or rote or poorly paid, especially if there's more interesting and or more lucrative work that they could do if they're not doing those menial things. And that's often the way the technology sort of begins embedding itself in the system. But when there isn't, when you talk about the technology replacing a human being, expect massive pushbacks from incumbents. And when I talk to digital companies in Silicon Valley, they say, oh, we're not too worried about that because we figured out Uber or we figured out financial tech. And I say, doctors are much better lobbyists than taxi cab drivers. Don't trivialize. When you say, I'm going to replace the radiologist, wait till the radiologists are out there on their ads saying, showing the technology that just killed someone because we gave agency the technology. We need me to read the film or read the x-ray. It will come if they feel like their jobs are threatened. So much depends on who's at risk for the cost and quality, and the liability landscape will also have a vote. So if it turns out a patient dies because a path slide was misread or an x-ray was misread, the question of who is liable for that will be a very big deal. But if machine learning and AI is ultimately better and cheaper and not demonstrably worse, I think it will ultimately win. I think that is inexorable. And then again, people will be able to buy up like business class to a higher level, more high touch care. But the basic, what you will get covered by health insurance will be through this kind of system. Now, you'll hear people talk there are a lot of studies that give you kind of a nice warm fuzzy answer, which is it's not actually replacing the doctor. It's that a doctor plus the technology is better than either one alone. That's also been shown in chess, that the chess AI is better than the chess master, but you put the two together, it's better than either one alone. It's kind of nice because it leads to this warm and fuzzy answer. I was talking to the head of Google Health the other day who said, we're not here to replace doctors. When you hear that, I think your BS detector should go off because that's the right thing for them to say. But of course they want to replace doctors. If they can come in and take over the entire task and take all of the economic benefit of that, then of course that's what they want to do. So what should we do and think as we enter this new and I think very exciting era of AI? I think AI will ultimately transform healthcare, decrease friction from lots of processes, cut waste, pushing care to lower cost and more convenient people whose work will be augmented by technology and also organizations and technologies. And I think the great resignation that we're seeing over COVID will accelerate this because now not only might it be too expensive to have a doctor or a nurse or somebody doing things, you may not be able to find them. And that is causing hospitals to think about solutions that what if we can't find enough people? Now we really need technology to do the task. Expect a massively bumpy ride with iconic failures, political blowback, false starts, but it will ultimately triumph. And when I say ultimately, I'm not talking 2 years from now. I think this is a 10-year journey. I think that we should and probably will start with low-hanging fruit, scheduling, triage, scribes, translation, maybe as we begin to move into clinical care, maybe radiology and pathology, before we try to tackle the really hard things like AI replacing what a doctor or what a nurse does, AI as a diagnostic engine. And good organizations, yours, mine, and others, will begin building our capacity to use AI thoughtfully to improve healthcare value. And a lot of it really is thinking about who's going to do the work, what's the governance, what is the interface between research and education and the healthcare delivery system. Incredibly tricky. So let me leave you with one of my favorite quotes from Yogi Berra, who may or may not have said this, but I think whether he did or not, it resonates with me. In theory, there's no difference between theory and practice. In practice, there is. In theory, AI is ready for prime time. It's going to take over everything. Look at Netflix, look at Amazon, look at everything else. In practice in healthcare, this is harder than it looks, and it will take a lot of hard work on the part of all of us to get it right. Thank you so much for your attention. Really appreciate it.
Thank you so much, Dr. Wachter. I believe that we have time for one or two questions. For those of you that are joining us remotely, you can put those questions in the chat. We will have time later when we have our panelists with all of our speakers today. We can ask some of your questions. At that point, if there's questions in the room, please hold up your cards and we will come and get them. I did see people writing down some notes, but I will start off with a question.
Sure.
So I'm a pharmacist by training. And I think one of the challenges, I grew up when we started having the alerts about drug interactions. And so we were probably the first group that was doing the alert fatigue. Yep. And it doesn't matter. But I see the healthcare system where we have these bubbles. So you have your healthcare system here, and then you have your community pharmacy. And a lot of people now with CVS mini clinics and kind of these remotes, we have these bubbles that aren't connecting. Mm-hmm. And a lot of that has to do with safety of patient information. So how do we kind of get over some of those challenges to really automate our entire healthcare system?
Well, I have to say that the link between healthcare delivery systems and pharmacies is better than I would have expected, even though it's imperfect. But the idea that basically the prescription pad is gone and that you can automatically send a prescription to Walgreens and CVS is sort of impressive. That's one of the things that when you think about the connection between the healthcare delivery system and the outside world, that's probably the part that works best, believe it or not. The rest is even clunkier. Try to interact between the healthcare system and home care agency or oxygen delivery, or everything else is clunkier. So it's better. In part because the stakes are very high, it's very expensive, you got to get it right, the patient safety implications are very high. But it brings up one of the core challenges is what becomes the gold standard of information. So we talk about medication reconciliation. The medication list that we have in the hospital or in the doctor's office and the medication list you have at CVS or Walgreens may be completely different things, and you're doing med rec against what gold standard? I think it's incredibly hard. So that's not a technological problem. That's sort of an operational, quasi-logistics, quasi-ethical question of, like, you have to have a ground truth in order then to get it right. And the ground truth in the Walgreens world is problematic because maybe Walgreens has done some of my meds. Some of my meds I get delivered to my house. Some of my meds I get from CVS. So how does that get woven together? Those are sort of logistical and operational questions. I don't think the tech part is the hard part of it. But again, as you think about AI, all right, AI is going to look at my risk of bad stuff happening based on my meds. Well, if it's using my hospital med list, it comes up with one answer. If it's using my Walgreens list, it comes up with another answer. So you see a lot of opportunity for mischief. So that's why, the AI piece is almost the easiest piece here. It's like the logistics. What does that list look like? Where does it come from? How does it all get consolidated? And you might say, well, let's just dump it into one big data lake. Doesn't solve the problem, because if the things are all different, you've got to have what is the rule to reconcile these different things. It's a really tricky problem.
So that gets into the garbage in, garbage out sort of question as well. So we do have a question for the audience. So what has COVID-19 taught us about digital medicine and AI in the future?
I think it's a great question. I would say that COVID-19 has not created a tipping point for AI at all. And that's surprising. I would have thought maybe 3 years ago that if there was something like a pandemic, which usually accelerates transformation and innovation, AI would be the thing that would tip. And as I think about AI and try to think about an innovation in AI that really was decisive in COVID, I can't think of one. Where there were some other things that did hit their tipping points, and I think they're going to be meaningful for AI, but not AI in itself. The two big ones that come to mind, one is obviously telemedicine, which was a nothing and now is a big thing, and opens up the opportunity to deliver care that's not associated with patients coming into an office to get their care. And that opens up a huge box of, all right, we're going to be collecting data from patients all the time. It's this issue of care traffic controls. It's coming in. Telemedicine is one of the effector arms. How do we deal with all that data? So I think it's going to accelerate AI, but it didn't really happen in COVID. I think it's a foundational step for AI. So telemedicine and associated sort of digital-based care and the end of the geographic imperative for care delivery is a big one. Second one is also sort of related to AI, but wasn't AI, is step 3 on my 4 things that had to happen is you take the data and make sense of it and deliver it to people in ways that are useful. I go on every morning to UCSF's COVID dashboard. It's fantastic. It's up to the minute accurate. It shows me test positivity rates and how many people are in the ICU and how many people are on a ventilator. Up until recently, I can't think of a digital dashboard that was presented to people in ways that were used modern thinking about data visualization, completely up to date. In the old days, if I said as a leader in my system, I need to see what's going on in COVID, somebody would send me an Excel spreadsheet. Worthless, absolutely worthless. So I think the idea that everybody now got used to, and I think a little addicted to, attractive, up-to-the-minute dashboards taking advantage of digital data to present to clinicians and leaders and patients in ways that help them do their work, I think that's a big transformational step, and ultimately AI will be embedded in those things. But I think those are both foundational. I don't think it really accelerated AI as a thing in and of itself.
One last question. Are there other countries doing better on medical AI than the United States?
Not a ton. I mean, you hear stuff that comes out of Israel that's impressive. Israel is a small country with everybody's in one of 4 HMOs. Everything's digital. They got a lot of smart folks working on AI, a lot of investment in AI. So in the same way, a lot of the early clinical research in COVID came out of Israel. It's a place where, the use cases are easier. So you hear some stuff coming out of Israel, a little bit of the UK, because again, when you have a system where everybody's data is basically in digital systems and it all is pooled, it's easier than this incredibly fragmented healthcare system. It's not just fragmented in the Michigan Health or Michigan Medicine versus CVS and Walgreens. It's Michigan Medicine's data versus what's in Beaumont versus and your patients are wandering to all of them as opposed to, so in the US, the VA would be a place where you would think that they would have a selective advantage in using this data. Healthcare organizations are beginning to think about this in new ways. So University of California, we're part of a statewide system of 5 big academic medical centers. I can tell you we do nothing together. But this is one thing where we've all agreed we're all on Epic, we're all sticking our data in a central pool because we think having 5x the amount of data is probably more useful than having 1x. So we're beginning to see it. I don't think there's any country, Israel would be the one I'd look to, but I don't think there's any country that's like really around the corner. It's hard, it's really tough stuff.
Great, thank you so much.
My pleasure, thank you.
Thank you again.